can be done, and then figure out how it can be done better. So when you compare the suture spacing, it makes less variable suture spacing. The burst pressure, after it has done in terms of outcome, it tolerates 4 times better. It makes less hesitations or mistakes when it's doing it. And time itself, we didn't focus on the time, but it is comparable to one of the current standards, which is minimal invasive surgery, putting 2 ends together. We have published a paper in 2014 on specifically on the speeding issue, and then you can make it as fast as you would like. So as a first-generation technology, this is pretty good. So what I've shown you is that slightly different way of doing surgery as move towards future in terms of working with the machine in a component way, if you will. The sobering part about this whole exercise was that we didn't add a huge amount of intelligence, but the outcomes were better than what we do in terms of current standards. So there's a huge room for an opportunity here. And the reason why we did it is because if you reduce complications, it's not only better for the patients, but ultimately it is a value proposition for the healthcare system and the society. And then we want to democratize it, as I said before, by making best surgical techniques to best surgeons anywhere, everywhere in the world, whenever you need it. Isn't that a nice idea, if you will? We are outcome focused, and obviously in terms of cost issues, if you reduce complications, it will have a huge impact on healthcare dollars. This is no different than the way life is changing in terms of life imitating art. You know, people used to laugh at Google for practicing this driverless cars. It's coming in many of the models within the next 1, 2, 3 years. I had a discussion with one of our senior leaders in the institute when I said 2020. People thought it was just a little too close, but future is here, as in we started with the aviation, we started with nuclear power plants and all these industrial complexes in terms of lifestyle and transportation, in terms of automobiles and so on. This autonomy and intelligence and making things safer, it's coming and it is here. And the reason why we do this is not because we don't enjoy driving. It's because it prevents about 6 million accidents each year in this country. It saves about 40,000 lives, if you will. Think about it. There was recent data from Canada that 30,000 people die each year in Canada alone, which is about 10 times smaller than this country from medical error. If you can reduce it, and then if you just simply multiply it by 10 times in this country, that will be the impact you will have by making things slightly safer and intelligent. This is a team. I like working with engineers because oftentimes I'm the sort of least intelligent when I usually bring the problem. I always want to know what we can do to solve the problem. And engineers always tell me what I cannot do and what we shouldn't do. This is a team from Huron Hopkins. Emma Leonard, Scott Mudge, Axel Krieger, Ryan Becker, and Justin Opperman. This has generated a fair bit of a controversy recently in lay public sort of media because there was some concern that we created some sentient being, Terminator, that goes on a rogue and operating on patients and so on. But again, I go back to the motivation of presenting this idea to you that ultimately this is to benefit clinical outcome and then safety and accessibility. So with that, I'm always plugging our WOFOPs. You know, we are the first North American center to host this World Federation of Pediatric Surgical Associations meeting this October. It attracts about 1,000 pediatric surgeons. Part of this meeting that we will have in October is to showcase some of the leadership that this country has displayed, and it's working out to be a sort of a successful one so far. So with that, I will turn it over to our next speaker, Dr. Aaron Kim, our oncologist extraordinaire. We'll have a question period at the end, maybe about 5 minutes or so.
All right, thank you so much. So I'm presenting on behalf of our image-guided non-invasive therapeutic energy, or IGNITE team. I'm going to start the discussion by giving a general background and motivation behind IGNITE, and then primarily focus today's talk on the clinical research program of IGNITE. So the mission of IGNITE is to improve the quality of life and outcomes for pediatric patients through development and clinical introduction of novel, minimally invasive, and non-invasive surgery technologies and combination therapy approaches. And we plan to do this by developing image-guided, high-intensity focused ultrasound, or HIFU, for pediatric applications where this technology is well positioned to impact current therapy. Now you may ask, why is there a pediatric oncologist here on Surgical Innovation Day? And the motivation for me is really because we need to do better for pediatric malignancies. We've come a long way, and we've got a lot better cures for pediatric cancers, but the cost has been very high. The acute and late effects of multimodal therapy in children are substantial, and multimodal therapy includes surgery, radiation, and chemotherapy. And our late effects impact all of our organ systems, including growth and development, secondary malignancies, and organ damage, and we need to do better for our survivors. And on the same hand, the cure rate for pediatric cancers have not been equivalent across all histologies. The prognosis for metastatic recurrent solid tumors, and particularly sarcomas, is dismal and really hasn't improved over the past 3 decades. So we obviously need improvement for therapeutic approaches in pediatric cancer. We need to think better, we need to think outside the box, and we need to think about smarter ways to deliver care. So what is MR-guided high-intensity focused ultrasound? So this takes 2 technologies, on the MR and ultrasound, and really combines them together for optimal care. So the MR imaging allows for precise target identification and treatment planning. So you can see the lesion and you can target it. And the MR imaging also provides real-time feedback regarding temperature change. You can actually measure the temperature in real time, and this integrated feedback allows the user to guide and precisely control the treatment. So here is the MR machine, and under here is where the HIFU system lies. And the HIFU is really an ultrasound transducer that focuses acoustic energy, and it focally deposits this energy into tissue. And by doing this, it can allow multiple amounts of thermal and biomechanical effects. So what are these biomechanical effects? So part of this could be thermal. So there is the transducer here, and it focuses energy to where you want to target the lesion. And you can target it so you can create enough energy and provide great temperatures above 55 degrees Celsius. Okay, it can also, you can deposit different amounts of energy to create what's essentially tissue hypothermia. You can actually target temperatures between 39 to 45 degrees, and this can enhance drug delivery, you can increase drug efficacy, you can create favorable physiologic changes. In addition, you can use the tissue motion of the ultrasound to even cause shear stress and hypertrophy or cavitation, which can create mechanical breakdown and cell death in that manner. So what are the advantages of MR HIFU? Well, as opposed to surgery or interventional radiology techniques like RFA, it is completely non-invasive. There is no needle, there is no scalpel, there is nothing that would penetrate anything in the skin. And as opposed to radiation therapy, it's completely non-ionizing. So there is no radiation involved because it's MR and ultrasound technology. It allows for large volume ablation, and it's got really flexible control over local heating. As we showed, you can create high temperatures to cause thermal ablation. You can create mild heat to cause hypothermia, and that can be used with other applications, such as really novel drug delivery mechanisms. And it's been well tolerated in adults with minimal or minor reversible adverse effects. Primary toxicities that's seen have been grade 1 to 2 burns, some edema, all of which reverse within 7 days to 10 days of application. And this device is currently approved for patients with uterine fibroids and pain palliation for bone metastases. So really, all these advantages make this ideal for development in pediatrics. So we have a variety of programs in the IGNITE. Our preclinical and clinical teams really discuss with each other and feed on each other to really provide bench to bedside translation. So some of the projects in our preclinical team are looking at not only marketing for benign and malignant tumors, but also leg length discrepancy by ablating physis. We are in collaboration with the Virginia Technology and the Mo Hospital for solid tumor comparative oncology program. Our preclinical team is working on HIFU algorithm. As you saw in the original slide, where the machine is, the ultrasound is in a little box on the MR platform. So there are some challenges in terms of patient positioning because essentially you need to put your tumor where that little box is. And so our preclinical teams have really been working hard in developing algorithms for patient planning. We're looking at MR histotripsy as well as respiratory motion compensation, and that's so we can use HIFU for organs, so not only in extremity and sarcoma lesions, but also potentially in liver lesions, lung lesions, and other sorts. Our clinical program primarily at this point is dedicated to benign and malignant tumors, and that's what I'm going to concentrate the rest of this talk on. So our first set of clinical trials, and this is run by Dr. Karun Sharma, one of our interventional radiologists, and he shared these slides with me. So osteoblastoma is a benign, relatively common bone tumor that occurs primarily in children and young adults. These lesions are small, less than 1.5 centimeters, that can cause significant localized pain. Many of these patients have significant pain at night. It wakes them up from sleep. It disrupts their everyday and quality of life. And the treatments have particularly been conservative, using NSAIDs, but again, you know, the duration of NSAID therapy is unknown, and there's lots of side effects, GI toxicities, and so maybe that's not the best thing. Surgical resection have also been used, but localization is difficult. These lesions are little, there's long recovery times, and so that's really come out of favor. And really the gold standard at this point is thermal ablation with CT-guided radiofrequency ablation. This is very effective in treating osteoblastomas, but again, requires an insertion needle, requires ionizing radiation for the CT guidance. So really a place where HIFU can be very applicable. So Dr. Sharma is running a clinical trial of MR HIFU ablation for pediatric osteoblastomas. And the primary objective of the study is to look at the safety and feasibility of MR HIFU for OO patients and children. So really looking to see, can this be technically successful without adverse events? We're also looking at preliminary clinical responses. So first looking at clinical assessment and follow-up, does the pain resolve? Looking at patient quality of life, and these are led by and developed by our colleague, Dr. Pan Hines, and looking at medication diaries, can we stop the NSAIDs? We're also looking at imaging response and MR at 12 months. So this is one example of a patient that was treated on our clinical trial. This is a 10-year-old girl with leg pain for about 7 months. She had no injury, but essentially she's unable to swim in her swim team. She's waking up at night. She's not sleeping well. And the pain is relieved with aspirin, but she's taking it 3 times a day. So again, you know, it's not a cancer. She's not going to die from osteoblastoma, but it's obviously disrupting her life and quality of life. So here is her pre-treatment MR, and this is without GAD and this is with GAD, and here is the nidus of the osteoblastoma. Very little lesion. You can see there's inflammation around. This is causing a lot of significant pain. This is the treatment, and so you can see Dr. Sharma can directly place the beam into where the nidus is located, and you can actually thermally map how much dosing of heat can go to that area. And then post-treatment, you can see, this is without GAD and with GAD, there's really no more contrast. And you can really see it in this post-treatment subtraction, where you actually don't see that nidus anymore. And this is all done, again, without a needle and without any ionizing radiation. And this patient, after a week of therapy, post a week of being done with HIFU, was no longer on any aspirin. She was able to join our swim team back in a month and really significantly improved her quality of life. And this is all done as an outpatient procedure. So again, this is unpublished data, but so far 25 patients have been screened, 10 patients have been enrolled, and 9 patients have been treated, and 2 have actually completed their 12-month follow-up. We've seen no major adverse events, really well tolerated. We've actually not even seen any skin irritation or burns. 8 or 9 complete responses, 1 of 9 partial responses. This is in a patient with a medullary osteoblastoma, a bit trickier than some of the other osteoblastomas. But the treatment times and anesthesia requirements have really been similar to RFA therapy, and maybe recovery might be a little shorter. So again, this trial is currently enrolling, and the data and more data will mature over time. So now I'm going to be talking about looking at MR HIFU technology for ablation of malignant tumors. So as opposed to osteoblast where you have that little nidus that was 1.5 centimeters, obviously we have a lot bigger challenges in terms of ablating malignant solid tumors. They're larger, they're irregularly shaped, and they can be located in any area. But still, a great area and focus where we can apply the HIFU technology to treat these tumors. So the primary objectives of this study is to determine the safety and feasibility and tolerability of MR HIFU for children with relapsed or refractory primary and metastatic solid tumors located in bone or in close proximity to bone. We're also going to be looking at secondary objectives, primarily to define tumor response using a modified RECIST criteria, and we'll also evaluate FDG PET as a modality for functional tumor response for those tumors that are FDG avid. Because sometimes if you ablate the tumor, you may not see immediate tumor shrinkage, but you could see immediate cell death. And we'll also be evaluating changes in blood immune markers, which I'll describe later, again, quality of life and symptom management. And to do this, we've actually developed a HIFU multidisciplinary team, and this includes our surgical colleagues, our bioengineers, our anesthesiologists, our interventional radiologists, and we actually review patient eligibility and imaging. The patient is deemed eligible, the patient will undergo MR HIFU ablation under sedation to a target lesion with a treatable volume for a maximum of 4-hour treatment time. And we selected this time to limit the total amount of anesthesia time that's exposed to a patient. The patient is followed for 14 days post-HIFU therapy to evaluate for adverse events. And we pick 14 days because most in the adult literature, all the toxicities have resolved by then. And in this case, for patients with other lesions or who want to go on to receive systemic therapy can do so in a short amount of time. For patients that have tolerated the procedure and have additional target lesions, subsequent treatment cycles are possible. So this is an example of one of our patients that were treated with MR HIFU, a third patient that enrolled. And the patient was lying prone on the machine, so the orientation is a little off, but this is a 7-year-old little girl with metastatic rhabdomyosarcoma who had recurred in a local spot right here. As you can see, this is our pre-treatment map. And again, by using the instrument, this is a transducer that's placed. You can actually guide and place the target. Here's the thermal energy that was placed on the tumor itself. And then based on post-procedures with subtraction images, you no longer see the tumor enhancement. And this has been sustained for a month. Unfortunately, she also has metastatic disease and has gone on to receive subsequent systemic therapy. So again, another place where HIFU can really be applicable for our sarcoma patients. This trial is currently enrolling, and our hope is to expand this trial to other sites, and that will be able to see, can HIFU be reproducible? It is user challenging, and it is user dependent, and so we want to see, can we see it across other sites, and also to increase accrual. So there are challenges to tumor location and size. There are challenges to artifacts. You know, many of our patients have prosthesis or because they've had limb salvage surgery, and if you can't actually MR the tumor, you can't really target it with MR HIFU therapy because we wouldn't be doing accurate temperature monitoring. Many tumors are located near vital structures such as arteries, veins, and nerves that we want to avoid with HIFU. And although HIFU can be precise, targeting the beam around that area can be challenging, and that's where patient positioning is quite important. But sometimes we can't overcome those patient positioning issues. Sedation, many of our patients do require sedation, and so we want to take that and be cognizant of that. And of course, metastatic lesions. Many of our patients come in presenting with, lung disease. Of course, at this point, HIFU, we can't target HIFU for our pulmonary nodules of our metastatic lesions. So one of the ways we want to try to overcome some of these challenges is looking at different mechanisms of combining HIFU therapy. So we, in the process of opening very soon, a phase 1 trial of Thermodox, a lyso-thermosensitive liposomal doxorubicin and MR HIFU combined for children with relapsed or refractory solid tumors. So lyso-thermosensitive liposomal doxorubicin, or LTLD, is a heat-activated formulation of liposomal doxorubicin. And doxorubicin is a common chemotherapeutic agent that is actually active in the majority of our pediatric cancers. And what it does is it's a really smart kind of drug that it releases encapsulated doxorubicin only with heating. And this is mild heating. This is heating up to 40 to 45 degrees. So it doesn't cause actual tissue ablation or cell necrosis through coagulation, but just causes it to heat. And what it does is that with liposomal, with thermodox, as opposed to doxil, right when the temperature is 40 to 45, it releases the doxorubicin. So it has optimized serum pharmacokinetics, and it uses heat, inducing medical devices to warm target tumor, and then actually rapidly releases the drug at the site you want it to be released, so at the tumor site. And in preclinical models, combining LTLD with MR-HIFU significantly increases the concentration of doxorubicin. This is systemic doxorubicin. And, we have kind of reached our limits of maximal therapy. So we can only give so much chemotherapy without killing the patient. But with specialized and thinking about different ways of giving medicine, you can actually increase the concentration of doxorubicin, even though the dosing can be the same, into the tumor target that you're trying to achieve. And it's quite sensitive and quite specific. When you actually compare the site of the tumor next to adjacent adjoining tissue, the concentration of doxorubicin is 43-fold greater compared to the adjoining tissue. And when they look at histology compared to free doxorubicin, thermodox, or thermodox with MR-HIFU, you can see the deposition of doxorubicin indicated in red is far greater than in thermodox alone or with free doxorubicin. So the objectives of this study is to look at the toxicities, to define the toxicities, determine the maximum tolerated dose or recommended phase 2 dose of LTLD administered in combination with MR-HIFU for pediatric patients with refractory or relapsed solid tumors. The first time the LTLD is being evaluated in pediatrics, and the first time it's actually being evaluated in combination with MR-HIFU ablation. We'll be characterizing the PK of LTLD, and then once once recommended phase 2 dose is determined, we'll actually be determining the feasibility of LTLD administered in combination with MR-HIFU using our mild hypothermia algorithm. We'll be defining preliminary the anti-tumor response and then changes in PD immune markers. This is the experimental design schema. You actually get LTLD and MR-HIFU on the same day. We will give myelosaturated on day 2, and then we'll observe in the end of cycle 1, which is day 21, we'll evaluate in terms of response. A patient will get 1 target per treatment cycle, and again, will be allowed to receive more if they have more target lesions. So one of the hot topics in cancer medicine is immunotherapy and the immune effects. And there's actually a lot of growing evidence that there is modulation of both adaptive and innate immunity through thermal ablation and mild hypothermia. There are changes in cellular immune response. You can modify tumor antigenicity, and you can upregulate heat shock protein. And so we are actually taking this and exploring HIFU as an immune modulator, and we're doing that in collaboration with the Kaplan Laboratory at the NCI. I think this will really lead to some very interesting secondary hypotheses and exploration. Can we use HIFU as a combination with immunotherapy? Can HIFU itself cause changes in terms of treating your primary tumor or causing abscopal effects on your metastatic lesions just by targeting immune therapy? So in summary, this is, again, preliminary, but HIFU does appear to be feasible for the ablation of benign and malignant tumors in children. I really believe that HIFU has the potential to replace current local control mechanisms someday, and we can hopefully integrate this into upfront therapy to replace surgery, to replace radiation for many of our solid tumors. HIFU can be applied to target drug delivery and drug therapy, and this is not only with smart drugs like thermodox, but also other medications like immune modulators, like immune therapy. And our current preclinical and clinical programs aim to guide clinical integration of this potential paradigm-shifting, non-invasive treatment option. So again, I'd like to complete off by acknowledging the IGNITE team led by Dr. Kim, Dr. Sharma, our interventional radiologist who leads the O studies and performs the HIFU studies. Matt Ogden, orthopedic surgery, Dr. Joan, the chief of pediatric oncology. Our biomedical scientists, the brains behind this program, Dr. Yarmolenko, Felix, and Aronki, and multiple undergraduates who they have mentors of the years that come up with a lot of the pre-treatment planning and positioning and the ideas to move forward. At Children's National, Dr. Hines, who leads the quality of life studies our anesthesiology colleagues, Victoria Bessian, the lead MRI technician for the MRI, Amanda Mahoney, our CRA, our NIH collaborators, our industry collaborators, Phillips and Celsion, and our funding mechanisms. And also, of course, to our patients and families.
The last, not the least, will be presented by Dr. Brian Reilly, and he's going to really tell you a little bit about surgery as a platform for reconstruction and regeneration, really the sort of next generation.
All right, thank you for that kind introduction. It's a real privilege to be here today. My talk is going to be about how we can hopefully take the world of 3D printing and translate that into improved care for our pediatric patients by essentially printing customized grafts to reconstruct their eardrum, which I think will dramatically improve the quality of care that we deliver. I'm the co-director of the Cochlear Implant program with Dr. Diego Preciado, and hearing loss is of great concern to parents because it affects their child's quality of life, affects their ability to learn, it affects emotional and social well-being. In adults, it can result in early onset dementia and depression. It can affect your ability to engage folks in conversation. And in children, if they're unable to hear well, then they're unable to acquire the basic building blocks of language and speech, which affect reading and learning and so on and so forth. I'd like to acknowledge my team here who involves Dr. Cleary, who can't be here, but he's the head of our engineering department, and our partnership with the University of Maryland with Dr. Fisher and Vincent, who have excellent research in 3D printing and stem cell research. So basically taking a step back to our Anatomy 101 class, the eardrum is of critical importance for your ability to hear. It's about the size of your thumbnail. It vibrates with sound waves coming in and then allows these opticals then create a electrical energy impulse to the cochlear nerve. But a hole in this eardrum will result in low frequency hearing loss if it's small, and high and low frequency loss if it's larger. And holes in this eardrum, which can occur from otitis media, are problematic because that impacts your child's ability to go to the pool party, to go swimming at the beach, because contaminated water that goes through the eardrum and essentially collect in this area and create pools of pus. We have many children here at Children's every year that we treat with tympanoplasty, but the problem is accessing this area, the fact that these defects are oftentimes irregular and hard to sort of measure, and then we have to carefully carve grafts by hand, and that is sometimes not very precise. And this is sort of a diagram showing a technique where you have to make cuts in the ear canal and then slide a piece of tissue to close the defect. So the goal of this research project was to use a small endoscopic camera. We have tiny little cameras now that can access all parts of the body. To go down the ear canal and take a precise picture of the eardrum. Then to use the 3D printer, which we have upstairs in our laboratory, to create a customized graft, which we can then pop into place, hopefully decreasing the length of the surgery and increasing the success and take rate of the surgery, since the success rate of the surgery varies from 40% to 90%, and there's that wide range because it's so difficult to get these customized grafts. And on top of that, we were thinking, well, maybe we could inject some special stem cells or growth factor into these customized little grafts to improve their take rate. So we've identified a graft material, which I'll describe in detail a little bit later. We've done the initial feasibility work on our chinchilla models, which are essentially a rodent that looks like a rabbit. It's ideal for studying otitis media. And this has all been done through JER funding and the CTSI grant that we obtained internally. So the clinical background, as I described, is the eardrum, the size of your thumbnail, can develop a hole either from barotrauma, from blast injury if you're involved near explosions, from an otitis media, which is the second most common pediatric infection, and most of these will heal. But about 150,000 tympanoplasties are done a year in the United States. and it involves usually measuring the defect and carving a piece of cartilage from your conchoidal bone or your tragal cartilage, and then carefully laying it in place. But it's hard to get that graft to snap perfectly in place because it has to have millimeter accuracy. And that can be difficult to achieve. So we thought, is there a better way to do this surgery? So what we've worked with our engineers and with our team is creating software that would capture points of the irregular defect, then estimate the perimeter from reference points, and then create a customized graft that would allow us to pop it into place. For instance, you could take a picture of the child's defect in the clinic, have the graft printed in preparation for your surgical date, have a few different sizes with a margin error, and then at the date of the time of the surgery, be able to quickly and meticulously insert the graft with improved take rate, decreasing the operative time, the amount of time that your child is under general anesthesia. So this is sort of the schematic of what we're talking about. Using an endoscope to get the image, measuring the image exactly in terms of its irregular shape, and then creating a customized 3D printed graft. The good news is that we have a 3D bioprinter here at Children's, thanks to Xited Institute, and 3D printing has been around since the 80s, but it's a really, I think, like self-driving cars and robotic surgery about to take off, because what it allows you to do is print cell by cell a perfect customized graft if you input the right stuff. So it improves not just education, but now it's really allowing us to create patient-specific implants. So many of us were victims who get flash trauma to their jaw and have to have complex reconstructions. Through the CTs, they're able to print, for instance, plates and bars ahead of time so that the surgeon can have them immediately available. We're hoping that we can do this for eardrums as well. So as I mentioned, we're in the preclinical testing state with the chinchilla, which is the ideal model to sort of study this. The eardrum in the human is about the size of your thumbnail. In the chinchilla, it's about the size of your pinky nail, so it's smaller and a little bit more tortuous. And we have essentially worked so far with 2 chinchillas, and we've had a 75% success rate, and I'm going to show you some of those details. We're planning 2 more series of experiments, one where we incorporate epidermal growth factor into the implant, and one where we have mesenchymal stem cells, which we'll harvest from the femur of the chinchilla. So this is the important background information that allowed us to move to the animal model. But essentially what we're trying to create through 3D printing, what we've been able to do, is a collar button butterfly graft that we were able to slowly assemble together with this gelatin support. Here you can see, and then we do a washout, and what it essentially creates is a plug that you can very neatly snap into the defect of the eardrum. We tested to make sure that we could have sub-millimeter accuracy, which we were able to achieve with our printer. And then we had to make sure that the graft had stability. And the drum has got to vibrate very carefully, both low-frequency and high-frequency sounds, in order to maintain the fidelity and allow you to have the appropriate hearing. We didn't want one that was too floppy because these chinchillas move around in the dust bath, and that could just fall out of the ear. We didn't want one that was too stiff, just plugging up the hole and preventing water or dust from getting in wouldn't necessarily give you the biomechanics you need to improve the hearing. So we're able to achieve that. We also demonstrated that not only once you print the gelatinous methyl acrylate graft, you can also then paint it almost with layers of fibroblasts or stem cells. So we're planning to do the next few series with these grafts impregnated with stem cells and with this growth factor. And you can see that it migrates as you paint it throughout the material. So here's our laboratory setup over at MedStar. Here's the OR table where we lay the chinchilla down. Here's the video setup, and here's the endoscope, which we then are able to visualize on the monitor here. And this is a measuring of the actual defect to help us capture the image. This is a video of the punctures that we created in the eardrum. So essentially, we took 2 chinchillas. They obviously gives us access to 4 eardrums. We went down with a sharp pick and we popped open the eardrum, just like what would happen if you were to get bumped while using a Q-tip or for instance, a firecracker will explode next to your ear, and you can see over here the defect. This is the irregular defect, which we then screenshotted, took a picture of, and then we're able to go back to our laboratory here and print a customized defect. Now, these defects will close over time. You know, the holes have a tendency to try to close, but not all of them will, and that's because in order for cells to migrate, they require a scaffolding, and that's the whole purpose of the defect in having stem cells. So we had 4 perforated eardrums. We did the initial puncture, and you can see that these holes, the area and perimeters changed a little bit. They got smaller. And we put in the grafts, and 3 of the 4 healed. So that was a 75% success rate on our toothed animals. And let me show you essentially what the graft looks like as it goes in. That's the graft in place. But hopefully I can get this video to play here. Here is the graft. So we endoscopically take this graft. It's like a collar button, or a plug, or a button you might have on your shirt. You slide it down the eardrum, and then we delicately insert it into the defect. And a week later, voila, healed. That's that same animal. Now, 1 of the 4 animals had a significant otitis media, so that's something that we're still working through. And we're planning to do subsequent tests with, again, the growth factor and some stem cells. But when we took our 2 chinchillas, we made different size holes in different areas of the eardrum, and we printed our graft, and there was some slight change in the size of the perforation as it was trying to heal up a little bit, but the perforations were still present 7 days later. And we popped in a graft, and 14 days later, 3 of the 4 had healed. So in conclusion, we are optimistic that 3D printing can really help improve this surgical outcome for about 150,000 patients a year. It can help children hear better. It can also help them enjoy water and not have an increased risk of infection with water exposure. The benefits are there's no donor site morbidity. Normally you have to make an additional cut, harvest cartilage or fascia. This we could simply size the defect in the clinic, print the customized graft to order for the OR. That would cut down on operative time, increasing efficiency. And we think that this, all in all, would be highly appealing to parents and patients alike. Thank you.
We have 4 minutes. Questions? Yes, sir.
The interesting thing about, so how does the graft stay in place? How do we ensure that it doesn't dislodge? In other parts of the body, we're able to use sutures or glue. Well, sutures you can't fit down the ear canal, and glue could glue the ossicles together. That is exactly why millimeter, sub-millimeter precise printing is so important. We create essentially a butterfly with an inner flange and an outer flange that straddles the eardrum with a 2 millimeter offset. So essentially, you pop it into place almost like you would patch drywall with a little bit of overhang on the lateral surface, and then it sits snugly in place if you carve it or print it perfectly. That's why it is so critical to have the perfect size, and why so many surgeons struggle to try to get it into